Nasz dzisiejszy temat Understanding Clinical Management of Intersex as a Critical Clinical Psychologist. Naszą ekspertką, now our expert is Dr. Li Mei Liao, and I am Katarzyna Morawska from DIMPACT, and I will host this webinar for you. Please, Li Mei, could you start your presentation? The floor is yours.
Okay, thank you. Thank you very much, and good evening, everybody. I'm Li Mei Liao, and I am speaking from my home in London, and I'm 1 hour behind you, so I'm maybe less hungry for dinner than you are. It's a great honor for me to present at this webinar, and I'd like to thank KPH in Poland for inviting me, to Joanna for liaising with me, thanks to Magda Rakita for the introduction, and of course to Kasia for her guidance. I think she's a Zen master in her spare time because she's been so patient. So I'm a clinical psychologist, and my interests are in critical healthcare psychology, women's health, and in sexology. Don't know who you are, so it's my first webinar experience, so it's slightly strange. But if you're very welcome, and if there are people with intersex variations, I'd like to extend a special warm welcome to you. It's a great honor to have your presence. So the reason why I was asked to give a webinar on intersex is that, as a psychologist, is that first of all, there are very few psychologists working in this area. And I have worked since the late 1990s in this area, doing research and doing clinical work with adults diagnosed with intersex conditions. And I work very closely with medical doctors, such as endocrinologists, surgeons, and also other scientists, such as geneticists. I also really value my work and interactions with intersex support and advocacy groups in the UK, in the USA, in Italy and Spain, and hopefully one day in Poland too. So, okay. I describe myself as a critical psychologist, and I want to offer you an explanation of that. Psychology is, of course, a natural science. Certainly in Anglophone societies, it's taught as a natural science. So there is sometimes a sort of claim of neutrality that we're scientists. Being a critical psychologist, what that means for me in this field is that I'm not neutral. I don't believe that we can be value-free working in this field. I understand medical interventions to normalize intersex as underpinned by social norms about sex and gender. And that I don't think it's okay for psychologists to ignore how social structures shape our thoughts and feelings and action in relation to intersex. And I think we should all be deeply suspicious of so-called objective truth claims. I think it's an area that we need to bring some, quite ongoing self-reflections, because we ourselves, every human being, has a sexed body and a gender, and the way that we respond to differences is deeply informed, not just by something neutral coming out of our head, but by our social context. And so that's how I understand critical healthcare psychology in this area. So this is the plan of the webinar. I'm going to talk through a few slides about what is intersex and to introduce you to the topic. I'm making no assumptions of any prior exposure, so if you're already an expert, please bear with me. And then I want to walk through what's controversial about medical management of intersex. And I like to walk you through a few slides as to what do we know about patient experience, and to cite some of the research with adults who have been cared for as children. And then I want to just quickly move on to, how things are now. Have things improved? And what else needs to happen? And somewhere along there, I'm going to invite you to chat, okay? So we'll see how this works. As I say, it's my first webinar experience, and I hope that's not too ambitious. So chapter 1, what is intersex? So the term, we need to start with terminology. The term was introduced in 1917, nearly 100 years ago, to refer to heterogeneous variations of physical sex development. So those of you who are interested in looking at the history of that, I would invite you to read the work of Alice Strager, who's a historian who's done a lot of work in this area. So I'm going to fast track us to 2006, where for the first time the term disorder of sex development, DSD, was introduced, was launched. Sometimes it's now referred to as differences of sex development with the same acronym, to encompass all genetic conditions where the development of chromosome, gonadal, or anatomical sex is not typical. So you will also come across terms like intersex traits, and that refers, it appears more in psychosocial and advocacy literatures to research to particular bodily characteristics. And more recently, the term variations of sex characteristics, VSC, has been introduced, and it is taken up by certainly quite a few advocates and activists. So it's important to emphasize that people with intersex traits may self-identify as female or male, or intersex, non-binary, etc. And that just like people without intersex traits, they may be attracted to persons of any gender. And people with intersex traits are as different from each other as people without intersex traits are different from each other. So we're not talking about any particular type of people, but very, people very, very individual. So the reason why I've gone through those terms is that actually in this webinar, I use the word intersex to refer to variations in biological sex development, not as a gender identity. And I will not be focusing on gender identity. So in terms of how, so what are these kind of traits? So what we're talking about are different combinations of chromosome, gonad, or anatomical sex characteristics. And that some traits are external, so therefore they're visible. So when a baby is born, maybe the genitals look a little bit different. The people in the room in the labor ward may feel a little bit confused as to whether the baby is more a boy or a girl. So the baby would have come under pediatric care. And it's important to bear that in mind, is that not all intersex people would have been identified, would have had their condition diagnosed in childhood, because some traits are internal. And therefore the baby presents as a regular baby, is just quickly assigned as boy or girl, and no further questions asked. But then later, certain signs, prompt investigation, and the diagnosis is made in adolescence. And sometimes that's missed as well, and it's in adulthood. So some intersex conditions are associated with illnesses that require medical treatment. We're focusing, not questioning so much on medical treatment to keep the baby or the adult healthy, but on certain kinds of treatments that's actually on intersex traits that are not medically threatening. So I want to offer you a few examples. For example, imagine a baby with 46X chromosomes, which is very typical for females, with ovaries, with uterus. And so because of the fertility potential, these babies tend to be assigned female, but they may have a larger clitoris, fused labia that may sometimes look more like a scrotum, and they typically have a single urethra vagina opening. So there's an internal vaginal structure, but it shares a common opening with where the urine comes out. Another example is a baby with 46XY, male typical chromosomes, and a urethral opening that's not at the tip of the penis, but at any point along the underside of the penis or at the base of it. So this condition is known as hypospadias. Another example is a woman with 46XY chromosomes, internal testes, no uterus or cervix, and female typical external genitalia and a smaller vagina. So this condition is known as to doctors as complete androgen insensitivity syndrome, CAIS. And these conditions are typically not diagnosed until later. For example, when periods don't come, when the girl doesn't menstruate and she's well into her teens. And there's another condition which involve 46XX, functional ovaries, but no uterus or cervix and a smaller vagina, called MRKH syndrome. So apologize for the being so medical here, but I think it's important to recognize that there is a biology there. It's not a question of gender identity only. So words like different, abnormal, ambiguous genitalia, atypical, are not easy, comfortable terms to hear and to live with. So, and there are some differences between conditions that are diagnosed at birth and some differences between those conditions that are diagnosed later in adolescence, because I think children who were diagnosed at birth probably will have a more medicalized upbringing. They will remember as adults going to see doctors, being examined. So I'm going to talk a little bit about that. Whereas people who are diagnosed later on, they would have had a regular childhood. They didn't suspect anything. And in the old days, there was a lot of secrecy. They were being lied to, they were not told the truth, and they were just very confused about what was going on for them. So what's controversial about medical management? Clearly, treating sickness is not controversial. So what we're talking about are intersex traits, differences that are medically benign. So, it's a dilemma. Do they require treatment, or is that a good thing? Let's think about that for the rest of this webinar. So I want to offer you an example. This is published in the Journal of Pediatric Urology. A parent said that recalling the birth of her baby, it feels like the baby you had might have to pass away. And that instead there might be this new baby with a different sex whom you'd learn to love too, but still the child you had would be gone forever. So it's referencing that actually the baby that arrived is different, not what the parent was expecting. So I like to now pose you a question on the chat how would you respond to parental distress? Because the distress is very real. You know, the parents are expecting, you know, a regular healthy child. They're not expecting to the baby to arrive, and then the doctors and the midwives feel very confused as to whether they have a boy or a girl. So their responses are very real, normal, to be expected. How would you respond to that? Anybody like to think about that? Or shall I move on?
Okay, with compassion. There is a first answer and the second one as well, by giving them a chance to
Yeah.
meet an intersex person. Okay, could you?
Fantastic. Yeah. Okay. So, any other responses from you?
Talking about fears, normalizing emotions.
Mm-hmm.
This
Yeah.
is like a question.
Yeah.
With normalization of their feelings.
Yeah.
Mhm.
Okay. So thank you for that. Let's see, where have I got to? Next slide.
Answers. Next slide is here.
Yeah, okay. So these are just my ideas. Different people will have different ideas. I think a clinical psychologist might listen to the parents' feelings with compassion, as you say, normalize their feelings, not being critical, not judging them, being empathic, share their feelings with them, and talk about the child using loving and respectful words. You know, it's a baby, it's a miracle, you know, congratulations. Tell the family that what matters the most is their love and their acceptance. And I think that actually you don't have to be a developmental psychologist to know that that's the biggest factor in terms of how well we grow up, how well we do. Ask the parents what kind of help they need. They may not be able to answer that, but I think it's really important to keep offering that. Give information about other parents, about support groups, resources developed by adults or by parents who've gone through the same process. And this is now the difference between a critical clinical psychologist and a clinical psychologist, is that I would help the family when I have formed a relationship with them to start questioning normal. You know, this importance of doing normal, this fear of not being normal, what does that actually mean? And if the parents raise the questions about normalizing the child's body, really helping the team to be totally honest about the risks, the controversy, the ongoing medical scrutiny of the child's body. Because I think once you interfere, once you carry out invasive interventions, the child needs to be checked. Surgeons need to look at the results of, you know, what they've done and do repairs and so on. There may be observers, so we're going to go into that a little bit. And so there is a treatment. Hang on, we're not ready yet. Have I? Yeah. So it's not just about like, well, we'll just do this one thing and then it's finished. You know, the child is normal now. It's not as simple as that. And if the team is offering these treatments, these normalizing treatments on intersex traits, it's really important to work towards an ethically and psychosocially informed protocol to make sure that's in place and to make sure that parents are not making decisions under high emotions. So instead, this is what used to happen. Okay, not in every case, but it's typical medical responses in the past that your child has a medical condition. We are the experts. We can do a one-off operation to normalize the ambiguous genitalia. And that doing the operation young is really important. It means that your child will heal better. They won't remember the operation and will just grow up normal and avoid being teased at school and being bullied and so on. So in the old days, and things are shifting, but in the old days, female assignment was favored, approximately in the ratio of 9:1. So intersex men were rare. And this typically, the female assignment is followed by feminizing genitoplasty, the surgery in infancy or childhood to make the genitals more female. What is feminizing surgery? Well, it's surgery on the clitoris to make it more female. So in the old days, it was a straight amputation, quite often clitorectomy, or clitoral recession, clitoral reduction. You come across these terms in the surgical literature. And the one-stage feminizing surgery also included vaginoplasty, you know, and that's really extremely controversial because a baby girl doesn't need a vagina. She's not going to menstruate and she's not sexually active. And there's actually vagina stenose. Once you operate on the vagina and it will scar and it will shrink. And that's actually the child had to be dilated, and it raises really huge ethical issues. And obviously modifying the labia, and where the baby was XY and female assigned, typically they would have a gonadectomy, so the gonads are removed. Okay, so all right, so why do that? So you could see that they're kind of pretty invasive procedures. The rationale was that to make the genitals look normal, the parents will be not so anxious. It would stabilize their gender identity, so the child would grow up, knowing that I'm a boy or I'm a girl. And it's supposed to prevent teasing. The child's more socially acceptable, and it permits sexual intercourse when the child is older and has grown up, and prevention of urinary symptoms. And I think maybe then we don't need to talk about this because we've got rid of the problem. So the earliest surgical publications were really about surgical techniques. They didn't do the research, but they would say things like it achieves near normal cosmetic and functional results, or normal clitoral sensation, 100% sexually gratified. However, these claims became challenged by adults who've had feminizing surgery in their childhood. And there are many, many resources to look at, but I will just offer you one quote from the Intersex Society of North America, which was hugely influential, but no longer exists. Genital normalizing surgery does not create or cement a gender identity. It just takes away tissue that the patient may want later. So the patient, for example, may reassign gender, and they could, the surgeons will then have more possibilities if there's more tissue to work with. So I want to now walk you through just a few slides about surgical studies. So these are studies with adults who've had feminizing surgery. So in 2001, a colleague of mine, she published a study involving 44 adolescent and young adult girls who had been operated in the same hospital as children. And so I'm sort of just moving I'm blocking my own slide, actually. That's the photo. So first of all, 31% of this sample already had 2 or more vaginoplasties. So we're talking about multiple operations. 26% had 2 or more clitoroplasties. So it's not one-off, despite all of them have been offered one-stage feminizing genitoplasty. And 98% require further vaginal treatment to permit menstrual flow or sexual intercourse. such as doing more surgery or using dilators. There are then other reports subsequently examining the same diagnosis, congenital adrenal hyperplasia, looking at their sexual concerns and identifying things like fear of sexual intimacy, holding themselves back, but also the people who then attempt sexual intercourse found it very painful, the vagina had stenosed, and there's some altered clitoral sensations. So when a surgeon performs these surgery, they're trying to make the genitals normal, so appearance is an outcome. Function is an outcome, such as menstrual flow, the vagina stays open and for menstruation and intercourse, but also sexual pleasure. Okay, so we're going to look at those three things one by one. In terms of genital appearance, all the early publications says that appearance is good, but there's no data. It's not based on research. And it's certainly not based on research of the patient's opinions. Long-term cosmesis was identified to be unsatisfactory by the surgeons themselves in 28 to 46% of the patients. There's no research on what the patients felt. So now looking at vaginal surgery, vaginal stenosis was very common, ranging from 36 to 100%, which means that actually more operations need to be done. But the problem is that each operation will create scarring, okay? And now let's look at clitoral surgery. So this is a study that was published by our team, and we looked at 28 women with so-called ambiguous genitalia. And some had clitoral surgery and some did not. Both groups had sexual difficulties, so it's not true that all the sexual difficulties are caused by surgery. But it's interesting that 25% reported anorgasmia, not able to experience orgasm after surgery, compared to 0% of those who have not had surgery. And then critics would say that, well, you know, there's no comparison with other people who don't have the condition. Maybe it's the condition that causes these problems. So a couple of studies compared the women with CAH and their non-CAH sisters and identified that there's more orgasmic problems in the surgical group, the CAH group. And actually, diabetes is also known to cause sexual difficulties, severe diabetes. And one study followed a diabetic population and a CAH population from the same hospital. So they were all followed up as children and found that there's far higher proportion of women with CAH with anorgasmia. So our team then looked at clitoral sensitivity, because a lot of people would say that, well, it's psychological, and what have you. So we actually looked at, I think it was like 22 women and some so-called normal controls to test their sensitivity using this rather complicated machine of volunteers to look at thermal and vibratory stimulation of the clitoris and vagina in women who had had childhood surgery. And there was significant impairment in sensitivity where surgery had taken place. So it's not true that, you know, it's a one-off and it would just normalize everything. So now I want to take a little break and pass it on to you and give you a little test, you know. So what have you learned about childhood genital surgery so far? Anybody wants to just say, remember from the last few slides?
have.
So I see that find some other case and present. What can be done when parents keep insisting on performing the surgery?
Lower, you have to go on
Okay,
the
shall I
bottom.
keep going? Yeah.
Okay, yes.
Okay, I'm going to come back to that question.
Sorry, there
Yeah,
is
go on.
some answers.
Okay.
It is quite controversial. Another one, just a moment. It is quite controversial, first one. Another one, in most or even all cases, one surgery is not enough. They have long-term side effects,
Yeah.
physically and mentally long-term risky. It can cause a lot of sex problems in the future. I doesn't guarantee better quality of life for the patient. It's risky, and outcome might actually be poor in context of patient's satisfaction.
Okay.
Okay.
Okay. That's very good. People have not fallen asleep. That's okay. All right. So I just want to sum up that what we know so far about childhood genital surgery is that the research is poor. Okay. And so that's why people keep arguing, because, it's actually quite hard to do very long-term research following a child all the way until they're sexually active. But what we know so far from adults is that multiple operations is never one-off. Very little research on the patient's own perceptions, their own ratings, their own evaluation about was it worth it. Vaginal surgery usually typically leads to stenosis, shrinkage of the vagina, and therefore it needs to be redone. And that alters, the clitoral sensations are altered by surgery. Okay, so I would say that it's a leap of faith to go from pediatric optimism, examination of children, to then project, generalize that to actual experience, sexual experiences of the post-pubertal sexually active adults. So moving on. The next chapter, what do we know about patient experience? So those are surgical outcome studies, but what do people actually say about their care? So there are many, many resources, many stories about how people evaluated their care. But I just want to direct you to one sort of source where it's kind of all compiled, if you want to look at it. So this journal, the Narrative Inquiry, Narrative Ethical Inquiry, published 18 stories of medical trauma. Okay, so it's a mixture of different kinds of problems. Some of the authors were born with atypical genitalia. Remember that intersex doesn't just mean atypical visible genitalia. There were also people born with typical external genitalia, but diagnosed later. And here are some common themes. Okay. Yeah. So the first one is that there's no psychological support. So this individual says that, learning that I couldn't have children really saddened me and shocked me. But there was no chance to talk about feelings either that day or any time afterwards. I was just told to stop crying. And I remember doctors telling me that there was no one else like me, that this was a random genetic anomaly. So the second theme that I could extract from that is the lack of good communication. So this individual says the saddest part was that I had to wait until I was 33 to find the truth, knowing all along that I was being lied to by everyone, undermined my trust in the very ones who were responsible for my protection and care. So a third theme is about being objectified. So this individual says, the first one, from the time I turned 1, I was subjected to genital examinations twice a year, during which time the endocrinologist would touch my genitals, look to see how they're developing. These exams lasted until I was 12 years old. Years later, as I began my adult sexual life, I realized how much those displays had affected me emotionally. So it's interesting, isn't it? Because the intervention, the treatment is supposed to make people normal, but they have highly abnormal experiences being medicalized in that way. And another quote, so many doctors were excited to look at me, to talk to me, to get a chance to meet me. As a child, it made me feel like a freak. I felt alone and scared, like I was on parade for all of these people who didn't know anything about me except that I was special. So now I'm quoting from what's published, but these are things that I have heard a lot of as a therapist, as a psychologist. They're not sort of unique to these 18 people by any means. I'm not saying that I haven't heard better stories, but I have certainly heard these. These were very, very common. So this two individuals says that I still struggle to understand how it could be that medical professionals who seem so interested in me, in my care, could have been so unaware of how the treatment had hurt me. The road to hell is paved with good intentions. Now, it's really important to bear in mind that everybody who provided care did it with the best intentions. They really believed that that was the way to be helpful to children and their families. Nobody set out to do something horrible, okay, but it sort of backfired. So what may be an alternative? This is a quote by Hida Veloria. I was born with ambiguous genitalia. It was a doctor who, by honoring my bodily integrity and not fixing me, gave me the greatest gift I've ever received. Because my body and its sexual traits are a positive, fundamental part of my experience and identity as a human being, I know that having my genitals removed or altered according to someone else's vision would have deeply damaged me, both physically and psychologically. So the next chapter, has healthcare improved? Well, yes, absolutely. And no, okay. What's improved is that this is a busy slide. I just want to signpost you to that if you want to find out more about it. So absolutely, certainly in my clinic, more patients have received their full diagnostic, their medical information much younger. So the stories that were very common in the first 10 years of my practice changed in the next 10 years. Also, there is a drive internationally to move from a surgical focus in healthcare to a team approach and to emphasize the importance of psychological expertise. But then if you look at psychosocial research, which is summarized very well by Katrina Rowan in a recent publication, is that parents are telling, when they are interviewed by psychologists, social scientists, they tell quite different things, so the doctor's not very aware of. So what do parents of affected children say? That despite all the information given, they struggle to make sense of the condition. They don't have the skills to talk to their children about DSD, and they're given medical information, but they don't have enough emotional input. What about parents and young affected people? What do they say? That their conversations with health professionals leave them feeling overwhelmed and struggling. Open are adults, adults who are aware of what's gone on, and even if they were given good information, most people do not feel able to talk about their difference with peers or sexual partners, and sometimes, occasionally, not even with their spouses. So whatever changes that have been positive we have been singularly unsuccessful as healthcare providers to educate the public, to make the culture more receptive, to make the sharing of information less high risk. So intersex and DSC services remain highly medicalized, and I don't say that lightly. I work in one of them, and it's a very progressive team. But on the whole, if you look at how the field is moving, it hasn't become less medicalized. So why is that? How is that medicalization maintained? I haven't talked about this, but I just like to hear your guesses. What do you think? And if you're not sure, we can move on.
I think
Shall I move on?
maybe after if somebody has a second thought. There is some
Okay.
answers. Okay, so what's okay. Um, it's easier to fix something than to change the norm.
Yeah.
It's easier to talk about medical stuff than emotions.
Mm-hmm.
There is no medical language, medical terms.
Yeah.
It's easier to give someone medical information rather than focus on feelings.
Yeah.
It's simpler because the medical norm seems more obvious than the psychological one.
Excellent. Yeah.
Mhm. It is still perceived as something clinical.
Yeah. Yeah. Well, thank you
Um,
for all those. Yeah.
it's another one. No, we are prepared to be 0 or 1, male or female, nothing
Yeah.
between.
Yeah. I think you know the next slide, because all those answers are excellent. So how does that happen? How is intersex medicalized continuously? Is that we use a disease-based language. We talk about disorders. We overvalue medical informational input. Like somebody else already said, it's easier to talk about that technical terms than to talk about emotions and feelings. And also the 0 and 1, very true. We fail to question binary understandings of gender and sexuality. Also, not enough support groups, and there are gaps in psychological care as an alternative to surgery. Like someone else has said, it's hard to change norms, but easier to fix the individual. So in close your eyes if you find this a bit horrific, is that in a recent study based in the USA, close to 100% of parents had opted for normalizing genitalplasties for their children. In the past, some things have changed, but not enough. In the past, doctors would say that your child's a medical condition, we're the only expert, we'll do this one off, your child won't remember, etc. Today, they're more likely to say your child has a medical condition. We are the experts, but other people can also help you. You can make your child's genitals normal, but it's going to be done in stages. But it's still better to do this when your child is young. The techniques are improved. Don't worry about those people who complaints from the past. And we'll leave to you to talk to your child. It's really important that you educate your child. Do it. But they don't say how. Okay. So why not just abdicate our responsibilities as a society to the medical profession? Doctors do their best, but they are limited in their knowledge and training in child development, family dynamics, gender and sexuality, meaning-based communications, intercultural, interfaith exploration of ethical dilemmas, effective collaboration with community-based agencies. So lots and lots of other people have the expertise to contribute, and it shouldn't be left to chance. So what else needs to happen? So health professionals, I think, should really make a commitment to collaborate with support groups. I learned so much from working with support and advocacy groups. That intersex DSD should be embedded in pre-qualification training for health, social and pastoral care providers and teachers. And that care providers, please don't say 100% satisfied or successful just because patients and parents don't complain. Do proper research. Thank you. So we have maybe just a little time for questions and answers from anybody.
Okay, what can be done when parents keep insisting on performing the surgery?
Okay, so I think that it's really remember at the beginning that we talked about how important it is to understand the context under which people make choices. So although it looks like parents are choosing, in effect, there isn't. What is the choice? It's either surgery or go home to somewhere remote and live with it. You know, so it's really, really important to provide some alternatives to the care path, for example, that involve, you know, consistent support, forming a relationship with a family, talk them through the worries, because surgery is something that can be done later. It's not like never. And so, you know, giving parents time, you know, or having a protocol that we want you to have these skills first to really bed down, you know, difficult communications to actually explore your feelings. You know, we're not even talking about surgery until then. So that's one thing. The other thing is that it's the when parents are, you know, they take a journey to this shiny building, they're given these medical terms. They are told to take the child to have various tests, and they're being examined, lots of experts talking to them, standing around. It's going to be very difficult for them to think that, oh, this isn't a medical condition, actually. This is just natural. You know, all children are lovable. When they're in that medical space, there is no space to think differently. And I think it's really important that, you know, parents are really making a choice when they are allowed that space, that there's a way of different ways of looking at what is different about your child, that you can think of it as some extraordinary medical condition, or you can think about that as really rather ordinary, and that it actually is not that rare. And there are lots of people that you could talk to about this, and that lots of people can help and support you when you start thinking about that. So I think that I don't think that it's just parents insisting on the surgery. I think they are being shoehorned, not intentionally by the system, but by a very medicalized language and a very, very medicalized system. There was a study done in Zurich, for example, when they have an actor, they have medical students acting as parents of a child born with atypical genitalia. And the actor for one group spoke to these, you know, surrogate parents, if you like, in very medicalized terms. And then the same actor claimed to be a psychologist and using different language. The first group were 3 times more likely to say that they would agree to surgery. And both groups felt that they had not been under undue influence, okay? So, you know, the medical context is really, really powerful in shaping those choices. And I think what we need to really focus on is really getting doctors to work differently, to really give, you know, genuine alternatives that parents can choose. That's what I think. Of course, the other side to that question, to the answer is that intersex activists are very successful in lobbying human rights organizations, and these surgeries are many major documents considered breach of human rights, abuse of human rights, and that they're working on a moratorium of surgery. And it may happen, but it doesn't get away from the fact that the parents need much more support than what they're getting, and to have a different language for thinking and talking about intersex.
There's another question. When is the best moment to talk with our kid about his or hers?
So I think that it sort of depends on the family, and depends on the child as well. I mean, you know, I think it's really important to talk about sex and difference, diversity. So to create a culture where, you know, as the child acquires the language, it's already being quite flexible about not just this kind and this kind of people, and being quite different, and about enjoying one's body and fun. And you know, I had one parent who said to me, you know, enjoy what you have. And so before even talking about intersex variations, to create a culture where the family embrace differences and is not afraid of it, and talk positively about it. And that what really is, you know, other sort of, you know, who we are, our personality, sense of humor, that we care, and having strong interests and passion and so on. So you kind of lay down that foundation to begin to, so that when you start talking about the child being, you know, your body's a little bit different, it works a little bit differently. It's not so strange. It's already part of the family culture to be able to talk about differences and diversity.
How it is possible that on one hand professionals overvalue medical information, but on the other hand, but on the other, the patient's children are still not informed enough?
Okay, so it's, I think there is a, first of all, there are lots, and so this is a big question actually, if I may break it up. So there are lots of differences between services and different countries as well, as to how much doctors communicate with parents and children. What's the sort of, you know, how competent and how progressive the team is in communicating information. So that's one thing. So it's not that all services are the same, and some do very well, and some, you know, need to do more work. So when what I think parents and patients need is to really have space to explore the meaning. You know, when you say, you know, you say that she's got this girl has a clitomegaly and virilization, you know, that's the kind of words that is like horrible. It makes patients, and actually there's research done that patients, to show where interviews with patients, they say that they just disengage from services because they start not hearing. They just kind of, you know, blank out because these are not really very nice words. So I think it's really important to not overvalue um, the technical information, but actually using kinder words and giving people lots of space to digest things, to ask, you know, what, or even what word should I use? What word feels comfortable for you? What's going through your mind now? You know, as I tell you about this, you know, what can you tell me about how you are responding to this? Do you need some space? Maybe sometimes not talking for a little while is fine. So it's about becoming more skilled in the way that we, rather than giving information, it's a process of information exchange, that the doctor becomes more informed, the health professional like myself become more informed about the patient, what they're preoccupied with, what scares them, what they're okay about. And the patient becomes, those words become, oh, okay, when you say that word, it was horrible, but now I see that actually it's kind of on the spectrum, isn't it? And so I think that the communication process needs to be oiled a lot more, and that it needs to be a lot more two-way. It's not us educating the patient, like throwing information at them, but to kind of really find out from them, what is it that you're not sure about? And, could we try different words for this? So it's a process of communication that needs working on, I think. Yeah.
If the childhood surgeries have so many consequences, is it reasonable to consider it as genital mutilation?
Well, some people consider it genital mutilation. I think that actually I think genital mutilation is kind of quite a difficult term. It kind of is that what are we trying to achieve by calling it genital mutilation? I think that the issue is that the child cannot give consent. So decisions are made by adults who is looking after their best interests, but when they're older, they may not consider that their best interests. So I think by calling it genital mutilation is linking that with female genital mutilation, which is criminalized, of course. And I can see that that is a kind of useful strategy to work towards a moratorium of surgery. But do I consider it genital mutilation? Women who have female genital cosmetic surgery, are the surgeons doing genital mutilation, changing what's healthy and working? And that's kind of, yeah, I'm not sure what I think, how useful that is as a concept. I think more about, I interrogated around it. Why can't we wait until the children are a little bit older and they can participate in conversations and give assent, even if they're not old enough to give consent? And why can't we wait until we see whether the child is, how the child is developing, which, in terms of genderedness, which way the child is going, what the preferences are, and to take those factors into account and allowing the child to participate. So I would kind of, I think more around, the ethics of the child not being able to consent, whatever we choose to call that kind of surgery.
The next one, can you share some case study examples? But I am not sure about what should be those case study examples. Could you reformulate the question maybe? Because, okay, and we will make it after when it will be more precisely formulated. Next one, is there any good script or procedure step by step for helping parents with intersexual child?
Yes, and can we be a little bit more specific there as well, for helping them to do what?
So we have wait for this because there is some more in the queue. So we will take another one and we'll wait for the reformulating. Thank you for an excellent presentation. How can the doctors get more educated except doing things on their own? Example, seeking support groups. Is there any provision with it within a healthcare service?
I think that most doctors in this field they're highly specialized and highly trained, and I think they consider themselves already very educated. Um, and so I think that it's down to, I think the most important thing is to learn from patients, for patients to be able to say that, you know, what's working well and what's not working well in terms of how they implement their practice. And that, you know, and that will highlight to the doctors what the gaps are, that maybe they need to understand a little bit more about, you know, some training in communication skills, for example, or that they need additional training in ethics, medical ethics, for example. And this can be part of the specialist training, you know, for the field. You know, even psychologists, you know, I learned on the job, you know, there wasn't any training for it. And lots of psychologists, not just me, can be very helpful, can do very useful work. But as well as being qualified, a layer of training that is multidisciplinary. It's not just about psychology, it's not just about ethics, it's not just about history, it's not just about medicine, but actually has all those elements to it. Then the whole team have to undergo that training. Would be what I'd really love to see, because I think that, you know, doctors, they're very educated in the medicine, and they're not sure. Sometimes you cannot know what you don't know. Okay, so it's really, really important for like advocacy and support group to help us to say that, you know, how about you do this layer of training, which give you, you know, a kind of really interdisciplinary approach to think much more holistically about the person, about with intersex traits. You're good at medicine, you're good at psychology, you're good at scanning. Let's now do a layer of training that really focus on the whole person, the development, the family dynamics, sexuality, and what have you.
Should we talk about these differences as a mutilation or variation? Is there one answer?
There isn't an answer. I think that all terms are transitory. The latest is variations in sex characteristics. That's come. I'm sure it's going to go. Something else will arrive. And the research that with patient populations is that there's not one term that's everybody, not everybody identifies with any one single term, and some don't like any terms. They would rather describe the actual difference, the actual trait, or the conditions such as CAH or CAIS, rather than DSD, VSC, and what have you.
The next one, is there any work being done with regards to using less medicalized terminology?
Yes, I mean, I think this is a question that the intersex advocates and activists are probably better at answering than me. So, for example, even doctors themselves, many doctors are not comfortable with disorders of sex development. So you more and more now see references to differences of sex development. Some have used diverse sex development. Other people talk about variations, intersex traits. So these terms are being introduced and are diluting so that there's not just the medical terminology there. So, yeah.
This is an answer because it was a question about how the education of doctors and script for how to talk about it, and this is an answer on the page on the website of KPAA. age.
Mm-hmm.
If somebody need it. Another question: how to tell the parents at birth that you cannot assign the child's sex? What words to use not to frighten them and minimize the trauma? I am Opgene, and it might just happen to any of patients.
Okay, so do chip in. I mean, I think that it's really important to start as a psychologist. I would say that sometimes by trying to our idea about helping patients avoid pain can backfire. So I think, and sometimes I think we want to, part of us, just like want to stifle the emotions a little bit, and start skirting around the issues. And that's also not helpful. I think that the parents are going to find it very shocking, whatever words we use. And I think it's really, really important to develop the relationship. This is my phone number. This is what you can call me any day. I will be the doctor. I'm in charge. I'm going to look after you and your family. And you can ask me any questions, and you don't have to think about all of it in the next 30 minutes, okay? So building that relationship with the family is really, really important. And accepting that the family is going to have big reactions and it's not your fault. So quite often health professionals are just so scared of, they kind of are very courageous in doing complicated life-saving operations, but they kind of fall apart, when the patient starts to cry or scream, because they're distressed. So I think learning to hold oneself as well, and using words, start with the kind of all the positive things, who does your child, who does this baby look like in the family? I do some work in maternity, and I quite straight away see that, the newborn baby always look more like one parent than the other. So you can kind of talk about the baby just like any other baby. Is the baby feeding well? Does it have, has it got, is it a bit naughty, or maybe very calm? Who's the baby more like? So talk about the child in loving ways. What do you enjoy about your baby? Okay. And then think about it. Well, say that you recognize these conditions. So rare. You've seen them before. Don't worry. We're going to just, find out more. And it's quite difficult that you can't announce the birth, whether you have a boy or a girl, but who else can help you? And how can we support you? So it's about using different words, talking about the baby as a person, talking about the family as a person, but actually not be afraid that they are going to have a reaction. They're going to be distressed. I think that, the parents will go through a grieving process because the child that they were expecting isn't here and they have another child, and it's a massive adjustment. And just make sure that they have good psychological support. It doesn't have to be somebody like me, a psychologist. It could be a very skilled nurse who understand these issues and can support the family, and that the team kind of is well organized. The family's not confused whose care they're under, who's going to look after them. And to I think words like your baby's meant to be a boy, but you think it may be better as a girl, or baby's a girl but the genitals are virilized, or we're not sure about whether the baby's going to grow up to be infertile. So I think these are kind of really frightening words, and I'm sure that you don't talk to parents like that. So you kind of find out from them, what's on their mind, what are they thinking, what are they preoccupied with, and what questions they have, and tailor the communication to them, but in the context of really talking lovingly about the baby.
There's another one. And regarding the person being objectified, I was wondering how we can prevent that, because in all medical specialties, you tend to focus on the affected area, but genitals are more sensitive and intimate part. Yet we have to supervise them. How, as a medical practitioner, uh, you can be careful with an intersex patients in that matter?
Okay. There's actually quite a bit of good research being done actually by medical doctors themselves, and sometimes in collaboration with psychologists, with mental health, that look at people's experiences, not in the intersex context, people's experiences of urogenital examinations. Sometimes these examinations are necessary. So that kind of research, unfortunately, is really based off one-off examinations. So what we're talking about in the context of intersex is that patients are quite often repeatedly examined. And somebody asked for, to share one case study. So I won't share the whole case study, but it was somebody who literally told me that this person, and I won't use pronoun because I don't want to compromise confidentiality, but literally this person was in hospital as a sort of, a child who's old enough to remember. And people would just, clearly the ward, the staff knew what was going on. The child did not. And people would just walk past and just lift up the cover to have a look, because, maybe that they've never come across children with intersex traits, and that sort of curiosity. So I think, the children are just overexposed. So from what we know in terms of the psychology of intimate examinations, and doctors have to do that, pediatricians have to examine children who may have been sexually abused or physically abused, for example. So there is kind of quite good protocol being established, but I don't see people referencing that in the intersex context. They don't borrow from other areas of medicine, areas of good practice. For example, examining children to look for signs of abuse, is having, in one of our clinics that look at childhood female genital mutilation, for example, there's a play therapist there, there's a pediatric nurse there, and they give the children lots of choices, they limit the number of observers, and they do that when it's absolutely necessary, and that the children are properly prepared. They talk about it, they sometimes use toys, but it's kind of, the kind of stories that you hear about when they routinely rock up in the hospital twice a year until age 12 to have a genital examination, and the genitals are not sick, right? So what are we doing there? What are these examinations for? Who are they for? So it's really thinking quite clearly about that, we need to, you need to supervise them. What does that actually mean? Are you going to do anything that's useful? And if you were helping the patient to consider the difference is kind of, natural on the spectrum, that level of tension is just telling them the wrong story about themselves, that is not going to be helpful psychologically. So I think that I would look into the kind of research into intimate examinations actually for children, for women, and for men. And there's some very good protocols already written up as to how to conduct those examinations in a kind of sensitive manner, and giving people a chance to debrief, to ask questions. I've seen pediatricians, for example, giving children a sort of a stethoscope, why don't you listen to me and see what you can find out, and so on. So it's there are ways, creative ways, to make that process less traumatizing. But I would say that limit that to the absolute minimum, because it's horrible. Um, it's not a pleasant thing to have. And if you're already different, you're going to be very sensitive to that.
This is the last question.
So this question is, to what extent are surgeries reversible? And what happens if the person who had surgery as a child identifies with the opposite sex in future? I'm not sure I understand that question. Could someone reframe that for me? Hello?
I can't see there is Eliza Nershevich, this author of this question. Could you please reformulate it, because we don't our expert doesn't know exactly what you mean.
Hello?
Hello? No, we don't have oh, okay, there is some. Okay, there's another one. So I met
Hi
3
there.
adults. Do you hear us? Hello?
I've lost you, but I'm not sure whether you can hear me.
Yes, it's again together. There is another
Hello?
question. Hello. There is another question, because we don't have the answer from Eliza
So
Nershevich.
if you can hear me, I'm going to read out the question anyway. I met 3 adults
Yes.
who do have that type of variation, but they refuse to identify themselves as intersex. Still, they all feel lonely, with a very medical term that they use for self-description. As a psychologist, how could I support them? Okay, that's a really good question. I don't think that any of these adults have to do anything differently. I don't think they have to identify as intersex. If they do, they do. If they need to come to that themselves. Intersex, I said at the beginning, is not an identity. It's not something that we impose on people. It describes bodily differences. So it doesn't surprise me that actually most of my patients don't identify themselves as intersex. I think the loneliness is something that as a psychologist you can do quite a lot of work with, signposting them to groups, forums, giving information about different kind of resources, maybe on the internet, if there's no real peer support there in where you are. There's a very good resource I use a lot, I signpost people a lot, is the Interface Project. So it's people with intersex traits talking about their experiences, and the theme is no body is shameful. So all the videos ends up with no body is shameful. So it's really important for these adults to hear other ways of living with these conditions, and it may be exploring with them, what's behind attachment to these medical terms. What do they mean to you? How important are they? Why are they important? And are there other ways of describing yourself that would make a difference to how you feel, make you feel better? And most of all, I think, to develop a therapeutic relationship with these individuals, working with them at their pace and not imposing anything. They've already been through so much. But also, it's important not just to focus on the negative, but I quite often ask people, what's working in your life? I know that you're lonely, maybe you're anxious, maybe you're holding back from relationships. Tell me what's working. to begin to get people to think of that actually they're not just their variation. Okay, there's much more going on for them. And ultimately, I think that's what I would see that therapy as going, is to get people to the place where, you know, they have some differences, but there's so much more than their differences.
Okay. We have two more questions, and this is the last questions we can speak about that, because we have spare 2 minutes only. Please, I assume the child had gender assignment surgery and later in life feels the gender assigned is not the gender the person identifies with.
Okay, yeah, that's a really, really good question, actually. And I think we need to, I think when pediatric teams work with the parents on gender assignment, and that's the most taxing process, it's highly, highly stressful, actually. And they try to assign a gender based on, you know, genetics, anatomies, and you know, fertility potential and what have you, and to try and assign a gender that a child is going to stay in. And I kind of don't have a problem with that, because, you know, that's a sort of, you know, that's a less complicated outcome. But actually, if the child reassign gender, you know, and is happy with the reassigned gender, I would also consider that a good outcome. You know, and that's really, really important to orient parents to, but actually, you know, to get away from sort of binary framework. And actually, I quite often talk to parents about, you know, actually in the general population, young people are being quite playful with gender. They experiment with non-binary identities, genderqueer identities, and these are not young people. These young people don't have intersex variations mainly, and actually, so your child could be one of those young people, you know, who kind of like, you know, I think I'm actually, this isn't right for me, and so reassigning gender, and the individual, the person is happy, I would consider that a good outcome, and that we should support the child and the family for that to happen.
Last one. From my experience, what types of for your experience, what types of intersex threats are the hardest for parents to accept? Which intersex threats are more often surgically removed or reduced?
Okay. I think that I think parents struggle quite a lot with chromosomes. Okay. So, for example, they have a daughter, and they have to talk to the daughter that the daughter has testes and XY chromosomes. They struggle quite a lot with that. Okay. And so that's a sort of not even a physical anatomical trait, but the kind of, but it is, you know, a variation. They struggle with the visibility of the genital differences. They worry. It's not necessarily that they don't accept the child. They struggle, they're kind of scared that other people won't accept, would reject their child, that the child will go up and find romantic partners, for example. So they're not sort of selfishly sort of scared for themselves. They're kind of thinking about the long-term future of the child. That if the child looks different, you know, how do they expect to, for example, if the child goes to nursery, you know, and or the childminder, the babysitter will change nappies and things, you know, they sometimes their fears is really down to quite mundane things like, you know, and then you know, if it's a small town or a village, is the babysitter going to tell everybody that their child is different? And so I think that, you know, they struggle a lot with just the fact that people can see. And then what happens when the child goes to school? This is why I think a really societal collective response is really, really important, that teachers have come across it, nurses have come across it, nursery teachers have come across it, that they don't sort of think, oh gosh, I've never come across this before. And that's why it's really important to embed that, you know. So when a parent approaches the school, they can already say, oh yes, I understand that. I've had some training and let's work together. Okay, that's what parents need. Parents do grow to really love their child, just like all other parents. They're not doing the you know, deciding on the intervention to be horrible. They really believe that that gives the child the best outcome, because they can accept the child, but will society accept the child? So which intersex traits are most often surgically removed? Well, I would say that the changing the external genitalia to align with the assigned gender, that's most likely to happen. So if the child's going to be assigned female, reducing the size of the clitoris, that's quite common. And I think there's some indication that actually fewer vaginoplasties are done on children, but I'm not sure. Yeah, this, and actually we're now at the stage where people are kind of, it's quite difficult to get at the information as to how children are being managed.
Thank you very much. Our time of the webinar is over, so I would like to thank you really very, very much for your big job, Li Mei. And before we finish, I would like just to say that this webinar was co-organized in the frame of the project Academia LGBTI, and this is the second webinar. The next webinar will be next week, so I invite you. It will be in Polish. Szkoła Równych Szans, Equal Opportunity School. Szkoła Równych Szans. Jak wspierać osoby transpłciowe. Spotka się z nami Dominika Rajska 9 października i oczywiście tak samo jak poprzednio rejestracja stowarzyszenia kampanii przeciw homofobii. A to webinar było realizowane przez DIMPACT, która wspiera cele statutowe Fundacji Rozwoju Społeczeństwa Informacyjnego. So thank you very much, Li Mei Liao, once again, and do widzenia wszystkim. Goodbye, good night.